Hello, in this lecture we will investigate electrolyte balance. You have already studied many of these electrolytes between Bio 119 and Bio 203. In fact, this table is from your Bio 119 book, and so I'm sure you recognize these major electrolytes in the human body. When we study electrolytes, they have many important functions, and as you read through the functions, you'll see they help with resting membrane potentials, action potentials, which have that depolarization, repolarization. We need them for all muscle contraction and nerve impulses, all those excitable cells. Some are really important for fluid balance. We know that calcium has multiple functions in the body. And so as we go through the electrolytes, we're going to focus on the ones in this table: the sodium, potassium, calcium, magnesium, and chloride. And we know that we take them in through what we eat and drink. We lose them through urine and feces. We lose a little bit of salt that way. We also lose salt when we sweat. Perspiration has sweat. And we lose even more if we were to have a GI disorder such as vomiting or diarrhea. And the kidneys are really important in monitoring and maintaining our electrolyte balance because our kidneys can, to some extent, control the amount of the electrolyte that's either reabsorbed back into the blood or secreted to exit the body in urine. We're going to start with sodium. You do not need to memorize the normal value. So what I would like you to do is know the electrolyte, know the main functions of the electrolyte, and then we'll also look at factors that affect it in our blood, such as usually hormones. So when we look at sodium, we know that in fact we probably get too much sodium in our diet more than anything else. So we gain it through what we eat. You can see a lot of our table salt that we add to foods. So typically we take in too much salt. We lose a little bit of sodium in our urine. And as I mentioned, we can also lose it through sweat. The main hormones that control sodium balance are aldosterone, and angiotensin II is here because remember, angiotensin II, once it's formed, will be a trigger to release aldosterone. And so aldosterone is critical because it really controls that sodium reabsorption in the DCT. The sodium reabsorption, remember, is talking about the sodium leaving the filtrate and going back into the blood. You might remember that angiotensin II, in addition to triggering the release of aldosterone, can also impact sodium reabsorption, but in the PCT. Now, most sodium is reabsorbed in the PCT. We said roughly 75% of it. But if you have aldosterone, that's when we get the rest of that sodium in our DCT. So if we're looking at the triggers for aldosterone or angiotensin II, one thing that's going to trigger it is going to be anytime our plasma sodium levels fall. Because if our sodium levels were to decrease, then that's going to be a signal that we need to raise them again. And so that's one of the factors. We also know that these are released anytime there's a decrease in blood volume or a decrease in blood pressure. Now, Addison's disease is something you learned in AMP1. And when we look at Addison's disease, this is hypoaldosteronism. You might remember that endocrine disorders can be hyper or hypo. So the aldosterone comes from the adrenal cortex. And in this disease, it's not making this hormone. And so what can happen if you don't have enough aldosterone is that you're going to end up losing sodium in your urine and water will follow it. So you're going to have low blood pressure. You're probably going to feel weak. For some reason, it can cause a change to the skin. It causes a bronzing of the skin, and I'm not sure why. But Addison's disease occurs from that. Now, ANF is the antagonistic hormone to aldosterone. You can also call this ANP, whether you want to call it atrial natriuretic peptide or factor. This comes from the atria of the heart, and notice it's both a diuretic and a natriuretic. Now, you know a diuretic is something that's going to increase urine output, so it's going to cause us to lose more water in our pee, and it's a natriuretic because it increases the secretion of sodium. So when ANF is released, it actually will cause your kidneys to kick out the sodium. So you're decreasing sodium reabsorption, which means it's leaving in the urine and water tends to follow, and so it's going to increase your urine output. That would lower your blood volume and lower your blood pressure. So things that typically stimulate its release would be anytime we had a high plasma sodium level, or theoretically we had a higher blood volume or higher blood pressure. And of course, we have hypertension in this country, and so we know that it's not just due to the blood volume that's causing the hypertension, or we would never have it because A&P would take care of that. Typically, remember, it's due to maybe atherosclerosis or blood vessels that aren't quite as flexible. Some other hormones that affect sodium levels are estrogen and progesterone. Estrogen tends to hold on to sodium, so it increases sodium and even chloride reabsorption, and estrogen is going to rise right before your menses, and so this might be why you retain water. You might get a little swollen, edema before your menses, whereas progesterone is released after your menstrual cycle has passed, and that works as a diuretic, and it helps remove all that water. If we have too much or too little sodium, we can have hypernatremia, which is too much, and hypo, which is too little. Whenever we have too much, it could actually make our cells even more excitable, because remember that sodium entering the cell is the first step to depolarize any electrically excitable cell. So these cells could become more excitable. If we have high sodium levels, we're basically dehydrated. If we have too much sodium, then we have more solutes, so we're probably going to feel thirsty, maybe be a little lethargic. Hyponatremia is not having enough sodium. This could be if your blood's very, very dilute, if you have too much water intake. We looked at this with hypotonic hydration. It could be some medications or excessive alcohol intake. And now we're going to have more muscle weakness and cramps because now we're not able to depolarize those cells. When we're looking at this disruption in sodium, if we're looking at hyper, we looked at the fact that if we increase sodium, then our plasma osmolarity is going to be too high. The blood's too salty. And when that happens, remember, that's a trigger for ADH. So I just wanted to bring ADH back as a reminder when we studied this with the urinary system. And then the ADH is going to open those aquaporins and try to hold the water to correct the hypernatremia. If we have hyponatremia, we have more dilute blood. Now we're going to inhibit ADH. We don't open the aquaporins, and so now we excrete a lot of water. We have a large urine output. And I had mentioned that it takes about 45 minutes to inhibit ADH. And so if you are drinking a lot of water or watery beer or alcohol, you'll notice it takes roughly 45 minutes before you start having to urinate more. Our other important cation is potassium. We know that potassium is the main one in our ICF, and it's critical for normal cell functioning. We need it specifically for that resting membrane potential. We need it for our neurons and our muscles to function, so we can say neuromuscular function. When we look at potassium, again, we know that most of it is inside the cell, and that created that diffusion gradient. Because there's more potassium inside and less outside, potassium wants to leave the cell. In fact, it did leave the cell through those leak channels, which is why our RMP was negative. So anything that disrupts our extracellular potassium concentration can affect this diffusion gradient and the resting membrane potential. You might also remember that once you got an action potential, you had your depolarization and then you had your repolarization when it resets. And that repolarization was due to potassium leaving the cell. So we could also have some concerns with the repolarization. When we look at potassium, we do try to make sure we take in as much as we lose. But when we're looking at it, one of the things with potassium is we lose it every single day in our urine. So we will always lose potassium in our urine, which is why it's important to make sure you're taking it in every day. We do know the kidneys can adapt if the potassium concentration in the ECF goes up, if there's more in your blood, and then the renal tubules will actually secrete even more to get rid of it. But notice they can't hold on to it if it should fall. We also know that it's critical when we look at the pH of the extracellular fluid. And we know that there's this relationship between pH and potassium. Remember that if we should have a pH decreases, that means that you have too many hydrogen ions. So now you're going to want to get rid of the hydrogen ions. So you would increase the hydrogen ion secretion. Well, potassium and hydrogen compete for secretion. So if I'm increasing my hydrogen secretion, I'm kicking that out into my pee, now I'm going to decrease my potassium secretion. And in fact, potassium levels could go up in my blood. I could have hyperkalemia from that. On the other hand, if my pH should go up, if my pH increases, that's because I don't have enough hydrogen ions. So now I don't want to get rid of them. So in this situation, I would decrease my hydrogen ion secretion. I need to hold on to them, but something's got to go. So now I'm going to increase potassium secretion. So more potassium leaves, which could send me into hypokalemia. And as I mentioned, we lose potassium every single day, and this is mainly due to aldosterone. Aldosterone definitely affects sodium. However, it's a 1-to-1 pump. So for every sodium that comes back, 1 potassium has to leave. And so we release aldosterone every day because we reabsorb most sodium from our urine, which means that every day we will lose potassium in our urine. It's estimated to be about 10%. So again, eat a banana, make sure you're getting foods that have potassium so you can replenish that. If our potassium levels go up, that would stimulate aldosterone because aldosterone's job is to lower them. So if we're looking at hyper or hypokalemia, we're coming back and we're looking at those cells. Now, hyperkalemia, remember, would be commonly seen if you had kidney failure because the kidneys aren't getting rid of that extra potassium. And so if we come back to our cell now, we know we have a lot of potassium inside, but what now if I have more outside? What's going to happen to that diffusion gradient? Will potassium want to leave? And the answer is no, it's not going to want to leave. So now it's going to stay inside the cell. So where we had our normal negative RMP, and then we always had this threshold level. Well, now potassium's staying inside, so my resting membrane potential is going to creep toward threshold. My cells are going to get much more excitable because we're getting closer and closer to threshold. It's easier to excite them and depolarize them. Often you have a tall spiked T wave as well on an EKG, and you could see it that way. And then as well, once we have this potassium and outside of the cell, this could also interfere with the repolarization stage. So at first the cells get really excitable, but then if this goes on longer, they actually can't, they kind of like run out of steam, so to speak. They're no longer excitable, and so then they actually become inhibited. Now, hypokalemia, on the other hand, we're looking at too low potassium, and this could happen from diuretics because every time we urinate, we lose potassium from our body. This could also happen if we had an issue with aldosteronism, having too much of it released. Notice hypo causes a small T wave, and it can cause what's called a U wave, which is this little U-shaped depression. Now, if we go back to our cell again, and now if I really shrink that potassium outside of the cell, now potassium really wants to leave. And if we lose more potassium, remember that is going to hyperpolarize the cell. It's going to make it more negative, which is going to be inhibitory. So you're going to have more muscle weakness. Remember that potassium, hyper and hypo, definitely affect your heart. They both can cause fatal arrhythmias and even cardiac arrest. Other factors that affect potassium. So we mentioned aldosterone will lower potassium levels in your blood because it's making you urinate it out. I would like you to know that cell damage often increases plasma levels because cells have so much potassium. When the cells die, they rupture, and all that potassium goes into your interstitial fluid and your blood. We already mentioned how acidosis could increase it, because remember, in acidosis, your kidneys will get rid of the hydrogen and hold on to the potassium. You don't really have to worry too much about these medications, but I would like you to recognize insulin. So you'll be giving patients insulin, and just understand that when you give insulin, it causes a reaction with potassium. It actually helps pull potassium into the cell. So when you give insulin, often the plasma potassium levels will fall. Calcium. Calcium is the most abundant mineral in the body. About 99% of all the calcium is found in the skeleton, in your bones. We know calcium is critical for several functions. In fact, if you just want the summary view of the importance of all of these, just go right back to the table at the very beginning of this lecture. We know we need it for bone density, our strength of our teeth. It's critical for muscle contraction. It removed the TT complex, so muscles would contract. It's critical for blood clotting, and we need it to release all those neurotransmitters. They won't be released at the synapse unless calcium enters. So it's controlled by two hormones, PTH and calcitonin. PTH is released from the parathyroid glands. These are glands on the back of the thyroid gland. And so PTH is going to be released anytime our blood calcium levels fall. So if you're not getting calcium in your diet, that's an emergency. Muscle can't contract without calcium. This goes for skeletal muscle, smooth muscle, and cardiac muscle, because they all had that TT complex, which prevented contraction from occurring. It prevented myosin from grabbing actin. When our calcium levels fall, PTH has a threefold approach. Number one, it's going to go to the bone, activate the osteoclast to pull calcium out of the bone and put it into your blood. It can go to the small intestine and increase the calcium absorption from food, and it can go to the kidney, and it can basically help your kidneys hold on to calcium. So it would increase the reabsorption. Remember, reabsorption is from the filtrate back into the blood. Calcitonin is the antagonistic hormone released by the thyroid gland. So calcitonin's trigger for release is anytime your calcium levels go up. So you're eating well, you're taking in lots of calcium. Calcitonin's released. It mainly stimulates the osteoblasts and deposits calcium into your bones. It can also increase the secretion of calcium by the kidneys. By the nephrons, so that you could eliminate more calcium in your urine. Now, if you're prone to kidney stones, you don't want to have a high calcium diet, because when you're eliminating more calcium in your urine, and if you're not staying hydrated, if your urine is more concentrated, especially with calcium, you're more likely to form a kidney stone. If we look at hyper and hypocalcemia, probably not going to see that as much as hypocalcemia, but if we're looking at hypercalcemia, you can see some of the common signs and symptoms, and you might wonder why it decreases the neuron excitability. It decreases concentration. It can cause muscle weakness, because I just told you it makes muscle contract. Well, there's a little complicated interaction going on here. We know that we had those voltage-gated sodium channels, and that sodium's going to enter that cell to depolarize it. That was pretty important when we were looking at contraction. Well, what calcium does is it kind of controls these channels. It kind of hangs out in the channel, and it controls how easily it opens. So if we have a lot of calcium, then what happens is this sodium channel won't open very well, which means that sodium can't come in and it can't depolarize and excite that cell. Now, if we were to have the opposite occur, so here's another cell, this will be my little sodium channel, and then I'll put my calcium. If we have hypocalcemia, now there's less calcium blocking that channel. So now sodium can get in even faster. So it's more excitatory. If you have hypocalcemia, you're more likely to have muscle spasms and muscle cramps if you don't have enough calcium in your diet. And so what happens is you don't need to memorize these signs, but what can happen is you can have this contraction that happens in like your hands and your wrists. And so they're just things that you'll see, these spasms can occur when we have calcium imbalances. Magnesium, we're not saying a lot about it. Just know most of it is actually in your bone and inside of cells in the ICF. It does help form bone structure. It's a cofactor for enzymes. Over 300 enzymes require magnesium. And we also know that magnesium can be inhibitory to calcium. So magnesium can actually prevent calcium from entering the cells. So if you give magnesium, you could actually increase the calcium levels. We also know that higher magnesium levels can be, they can be inhibitory on neurons, and they've been found to relax muscle. So for my son, when he had the epilepsy, we put him on magnesium, and he still takes magnesium because now he gets migraines, and the neurologists have recognized that, and we give him magnesium every single day. There's some evidence that people of higher magnesium intakes have a lower risk of heart attack because it seems to relax the smooth muscle as well. If we're looking at too high or too low, we're not getting too concerned about this, but notice you can have hypo. Hypermagnesia is more depressant. I mentioned that it can suppress muscle contraction and the brain at really high levels, whereas hypomagnesium is, by the way, usually due to malnutrition. Not taking in a proper diet can cause this, and this can cause cramps and hypertension. The chloride ions, all we're going to say about chloride is it likes to follow sodium everywhere. So sodium and chloride are BFFs. We also know that chloride is really important because it is critical for allowing us to transport carbon dioxide and forming that bicarbonate ion. And remember that the chloride and the bicarb went in opposite directions, and we call that the chloride shift. We're not worrying too much about abnormal chloride levels. This is more an FYI picture for you because you're not going to see a whole lot of issues with chloride. It mainly will affect basically fluid balance. So this concludes our lecture on electrolytes.